Well, welcome everybody to our Journey discussions. I'm Troy Kilpatrick, the Executive Director here at the Journey Museum and Learning Center. And I'm hosting tonight Dr. Shankar Kurra from Monument Health. And we thank all of you for signing in tonight for our Journey discussion. It's our first program here in 2021, and we think incredibly important. We've all been living this amazing story of the coronavirus pandemic that started in really kind of in March of last year. So we're getting close. We're getting close to me being able to get a haircut at the year mark, Shankar. That's how long I've gone with all of this. But what's a Journey discussion tonight, folks? You've signed in. You can send me questions in the chat at any time during Dr. Kurra's conversation, and I will track those for you, and then I will moderate those back to Dr. Kurra when he's completed with he's got a PowerPoint and slides, and Dr. Kurra is very detailed and has a lot of great information for everybody, but I'll moderate, I'll watch the chat, and so I encourage you guys to send those in advance so I can kind of get them organized for him once he gets to the end of the slide. And Journey discussions, just so everybody knows, we're going to be doing these every Thursday night for the next few weeks. As an example, over the next 3 weeks, here's some of what we're bringing to you. Next Thursday will be Mount Rushmore Visions, and we're going to be joined by Diana Nielsen-Sadoff and Maureen McGee-Ballinger. Diana is in charge of the Mount Rushmore Society, and Maureen is the Chief of Interpretation and Education at Mount Rushmore. That Thursday is right before President's Day, so you know there's a little bit behind what we're doing here, a little history, a little celebration of that independence. Following that, the following Thursday, NASA is going to be landing their new rover, Perseverance, and I think perfectly named after everything we've gone through in 2020, on Mars that day. And so we're going to have video of Perseverance landing on Mars, and then we'll be joined by Tom Durkin, who's the Deputy Director of the South Dakota Space Consortium working with NASA, to talk about what's next for NASA. What is Perseverance's mission? What's going to happen as NASA looks to put men and women on Mars really very soon. So that's going to be a cool program on the 18th. Lastly, February 25th, Dr. Chris Heacock, very special person here at the Journey Museum. She's our chair of our board. She's also written a book on forgiveness. And so we've aptly titled that Journey discussion, Forgiving 2020, because of everything we've all gone through. We've all had to endure changes that we didn't know we were going to have happen. And hopefully there's going to be some conversation points here for how all of us can do a little bit better with all of the changes and the stresses and the things that we've had to manage. And we thank Dr. Chris for her willingness to do the program and all of her leadership here at the Journey Museum and Learning Center as we build a bridge through 2021 and get to 2022. So Dr. Kurra here works with Monument Health, and let me just a quick kudos to Monument Health. They're on our front line. They serve over 20 communities through western South Dakota and eastern Wyoming, and there's over 4,500 physicians and caregivers within that network. And they're on the front line of all of these things, everything for us. And Dr. Kurra, we'd like to thank your team. We'd like to thank Monument Health. Your mission statement is make a difference every day, and I think you guys have. So thank you so much from everybody in our community. But let's talk a little bit about Dr. Kurra. He's a repeat offender here now on Journey Discussions. This is his second program. And it's because of how vastly important and how all of this has occurred. Dr. Kurra is the Vice President of Medical Affairs at Monument Health, and he oversees the medical staff there. And Dr. Kurra he earned his medical degree all the way back in 1991 from Gandhi Medical College. And then he went on to Indiana University Health Ball Memorial Hospital to complete his residency in internal medicines and a fellowship in geriatric medicine. His MBA was earned in 2010 from George Washington University. During the past 25 years, Dr. Kurra has practiced in emergency medicine, hospital medicine, and geriatric care. Dr. Kurra grew up in India and moved to the United States in 1995. He lives obviously here in Rapid City now with his wife, Sunitha. And outside of work, he enjoys golf, cooking, travel, astronomy, like NASA stuff, photography, and music. And Dr. Kurra is engaged in our community. He served on many nonprofit boards. He's currently serving on Wellfully of Rapid City. I will turn this over to Dr. Kurra, and thank you all. And again, I'll be monitoring the chat. And so, you guys, here we go. Journey discussion. Dr. Kurra.
Thank you, Troy, and good evening, everyone. Welcome to a discussion on COVID vaccines. So just as I launch my slides here, let me get to the slides. Okay, and we get that. Okay. Well, welcome again. So my talk here will be hopefully about 40 to 45 minutes, and then happy to take questions. I see a lot of questions already. I like that. It's nice to have an engaged and enthusiastic audience. So let's begin. So I'll give you a brief outline about the pandemic. We're living it. It's historic 100 years ago, we had a pandemic in 1918, and here we are 100 years later with SARS-CoV-2. Then I'll look at the vaccines itself, and then we'll go to some questions that are frequently asked, and then go through the strain variants that we're beginning to hear about a lot in the press these days. And then conclude with some comments about distribution and how we're doing it at Monument, and how you can register online and be on there to get your vaccine when it's your time. Okay, so let me do this. All right. So quick view of the pandemic. So a pandemic by definition means it is involving more than 2 regions of the world. So that comes from the words pan for all and demos for people. So a large group of people being infected by one organism causing this disease. And we've seen that through 2020, started in January in Wuhan, China, and then spread across the world. And there's not a nation in the world that has been spared. So give you an overview, we'll start with some numbers about the previous pandemics, starting with 1918, the Spanish flu. You've read about it, the history of it. At that point, approximately 50 million deaths. That's about almost 3% of the world's population, pretty large toll. Then we moved to 1957 with the Asian flu, the H2N2 influenza virus. So this is a variant of the Spanish flu, which was H1N1. And you can see again, 1.5 million deaths. Again, a large number that accounted for approximately, about 0.05% of the world's population. And just after that, 1968, the Hong Kong flu. All of these, as you can notice, are influenza viruses. H3N2, and again, that was a large toll, 1 million deaths. And that also marks the beginning of vaccination, at least modern vaccinations. 1967 marked the year the World Health Organization started a global effort, launched its project to eliminate smallpox. And you can see in the next 10 years, they succeeded, completely eliminating a disease, which is quite remarkable. So we will talk about that because prevention is the name of the game when it comes to vaccines. These are what are called preventable diseases. If we can get people vaccinated in large enough numbers, like they did in 1967 through 1977. So moving on, we get to 2009 and the pandemic caused by H1N1, another influenza, a repeat of the 1918 variant, but with some differences. And again, the total there was 300,000 deaths, a large number for a modern era, a fraction of the world's population. And here we are in 2020 with COVID-19, the disease that began November of 2019 and through 2020 Most of us are still, no folks that have had it, no folks unfortunately passed away, and 2 million deaths and ongoing. That's quite a large toll. So how did it all begin? If you look at the origins of this, start at the top of this picture, you can see there are two species of bats there, Rhinolophus, and that's Cynicus and Aphanus. So these two are where the proximal origins of SARS virus began. The question always comes, is this a lab, escape from a lab, or is it natural? The best evidence, and the more evidence we get, and they're getting closer and closer to it, and especially with all the changes we're seeing in the variants, it is very clear beyond any reasonable doubt that this is a natural spillover, what we call a spillover from a bat disease to human. And usually these kind of spillovers occur through an intermediate host. And you can see there are those hunters who supply live animals to these markets where folks then take these animals and they're used as food. And you can see in that picture there, as you look through there, there's a cage there. Hopefully you see my cursor with bats on top. And then inside the cage there's mammals. Here's a civet and here's a pangolin. And this is how the first SARS in 2003 occurred. And that was very contained. It did not spread too far and then disappeared from the world. But this is similar to the first SARS, and that was well documented. Here, we're still trying to figure out what the intermediate host was. And so from the bats to an intermediate mammal, and then from there, it spilled over to humans. Once it got into humans, for some reason, it transmitted really rapidly across among humans, and as you can see from China, spread across the world. So this is a good representation of the SARS-CoV-2 virus. It's a sphere, and it's a coronavirus. All coronaviruses are similar in that sense that they're spherical and have these spikes protruding. Remind you of the solar corona during an eclipse, or think of it as a crown. Corona in Latin is crown, but it was named because it kind of reminds folks of a solar corona during a solar eclipse. And so inside the virus, you can see there's a spiral that is the genetic material of this virus, and that's the RNA. In humans, the genetic material that is the blueprint for all of us is DNA. For this virus, it's the RNA. And you can see in that spiral, there's a part that is colored red, and that's just showing you this portion of the RNA that codes for the spike protein. And that's the target for most of our vaccines, because the only way this virus attaches to human cell is through those spikes. And once it attaches to receptors on the human cell, it is able to then fuse and enter the cell and then take over our own machinery to make copies of itself. And that's how it invades and causes all the damage that COVID-19 causes. At the bottom of that is the spiral RNA stretched out as a line. What I want you to picture this genetic material as a string of beads. And if you were to imagine this genetic material of this virus as a string of beads, there are roughly about 29,900 beads in there, or about 30,000 beads. And they're made up of 4 colors. And that's how RNA is. There are 4 colored beads, and they kind of, vary depending on how they're sequenced. And that's what you're seeing there. Think of those string of beads, 4 color beads, and then they arrange themselves. And this is how they code for different proteins, including the spike protein. And this is important as you go through my slides. As I go through my slides, I'll explain why, if you can keep that mental image of the genetic material of this virus. Okay, so you can see on the bottom right of the picture is China, and you can see all the arrows emerging from there. The darker shaded arrows are ones that led to sustained transmissions. The dot arrows that are dotted are the ones that did not sustain. And that's the nature of the transmission of this virus. Roughly 70% of folks who get this disease don't transmit it. So 30% or less, usually it's roughly in the region of 10 to 20% that actually go on to transmit. So it's kind of not homogeneous, or asymmetrical way of spreading, which makes it harder to contain unless you isolate and eliminate those kind of mass spreading events. And this is where the coronavirus has its ability to quickly spread across continents. It relies on human contact occurring in closed spaces and in large crowds, and that's where it does very efficiently spread. So that's how it did, as you can see, from China to Europe, Europe to the United States, and then on the East Coast. And on the West Coast, it came straight from China to the United States. And this is a genomic map. So what they do is take those beads and then see, based on how those beads are arranged, think of it as a barcode or a fingerprint scanner. And the barcode scanner, the scientists can say where this virus came from. So the initial spread was from China, but actually the vast majority of the spread in the United States occurred from Europe. And you can see that in the way those big, broad brush strokes of red are entering the United States, mostly from Europe. And then there's a large band of green and yellow also from Europe. But China itself mostly stopped once the Chinese were able to control the numbers in their own country. So once the spread was seeded into Europe, it spread rapidly there and then migrated quickly to the United States. This is an important slide in the sense that it understanding transmission. So if you look at the age groups here, you can see on the left-hand column from age 0 all the way to 80 and above each row. And in the middle column, you can see estimated transmission. So the darker shaded age groups are where the most of the transmission occurred. So ages 20 to 34, there was 35% transmission. Ages 35 to 49, there was 41% transmission. So just between ages 20 to 49, you have 76% of transmission occurring. So it's a very important fact. You have to realize that vast majority of the transmission is occurring among that younger cohort, ages 20 years old to 49 years old. And then also, if you look at the last column, is percentage of population that these folks make up. So they only account for roughly about 20% of the 20 to 34 and another 20% of the 35 to 49. So it's 40% of the population. And they're responsible for 76% of the spread. So this is very important in a lot of ways to understand how this virus spreads. Let's look at mortality. This is for a whole year, all the way from January of last year until December 2nd of last year. It's a 1 year's data, good indication of where most of the deaths have occurred. So if you look at the red bars, those are COVID-19 deaths. And then where the golden yellow line ends in each of those bars is the actual population. So if you look at the one with 85 and above, the golden bar is small. There's a very small number of folks there. But look at how many people have died in that age group. It's almost 32%. If you add up all the percentages, you can see that anyone that is 55 and older, all the way, those folks unfortunately had the biggest burden of the disease in terms of deaths. 90% of the 450,000 deaths that have occurred in the United States occurred in that age group, 55 all the way above. So that is the most vulnerable group, which is why the State Department of Health currently is trying to get those folks 80 and above vaccinated. And then we're starting to look at 75 and above very soon here. And then we'll keep going down 5-year gaps till we get to that 55 and above. Because those folks, unfortunately, bear the biggest burden of the disease. And if you look at the groups 0 to 4 and 5 to 14 and 15 to 24, there's really not much going on there. They've got some very, very minimal, burden as far as deaths are concerned. So you can see clearly it's very heavily affecting populations 55 and older. If we were to look at the deaths over the last 5 years, starting from 2015. If you follow along, that horizontal line at the bottom starts at 2015. And then you have intervals from 2015 through 2016 here. If you can see my cursor, there's a decrease in deaths. This squiggle here is the deaths that have occurred each year annually. And this line is the normal line. In other words, the average, if you average over 10 years or so, that's about where the deaths occur every year. And then you see it's kind of keeping to that average. Law of averages, it goes up, it goes down here, it goes up in 2017, goes up a little more in 2018. Then you have a year where it goes down. So it catches up to this normal, or this what's called the average line of deaths. But then you come to 2020 and we go into April, and we start seeing in the United States, April all the way into January of 2021, you have a huge surge in deaths. And this is what we call excess deaths. And these excess deaths are all deaths, not just COVID-19 deaths, all deaths that occurred. And so are these, and there was no COVID-19 here. So most of these extra deaths we saw here in the 2017-2018 flu season were obviously because of the flu. But here, these are all deaths, flu deaths, COVID-19 deaths. And if you take this entire number of 450,000, 80% have been directly attributed to COVID-19. The other 20% are the direct impacts of COVID-19. If you took a closer look at that, here's the United States reported deaths. This is through January 9th from March 15th. 446,000 excess deaths. That's 19% above normal. And you can see March, there was a spike. Then we had the summer spike. And then now you got the big one in November through January. This is for the United States. If we compared that to South Dakota, you can see that's a 25% above normal. So 1,600 deaths in this short period of time is 25% over what we would expect deaths in South Dakota. That's higher than the national average of 19% in all 50 states. So this is we are just unfortunately an outlier as it applies to deaths. Okay, so I will switch now and give you a little glimpse into how the vaccine got here this quickly. This is another question commonly asked. Folks always say, well, if this vaccine was built so quickly and marched out so quickly, maybe it is not safe. Maybe there's something questionable about how it got here. So hopefully after this section, you'll understand why we got here so quickly. So this is an RNA vaccine, and it's a new technology. So let's look at it. So the pioneers who are responsible directly for this breakthrough are these two folks. On the left, you see Katalin Karikó, a Hungarian-born brilliant biogeneticist who came to the United States and joined the University of Pennsylvania as a professor. And she spent 10 years from 1995 to 2005 without a professorship, without a lab. But she had already, had achieved a lot prior to that. And based on her ability to understand things, she persevered despite not getting any grants. Every time she applied, she was told no. And she is the reason, along with her collaborator, Drew Weissman at the University of Pennsylvania, that finally made the breakthrough that made it possible to even conceive of a vaccine using RNA technology. So that was in 2005. And from 2005 until 2020, the two companies that we'll talk about, Moderna in Cambridge, Massachusetts, and Pfizer-BioNTech in Mainz, Germany, they immediately latched onto this paper that she published in 2005 and realized its potential. And in that intervening years until now, from 2005, they built the prototype for the messenger RNA vaccine, and we'll talk about that. That is why we could get so quickly to where we are, because of the hard work done by these two scientists and by the two companies that actually were founded. Moderna was founded after this paper. The paper, when it was published in 2005, the founder of Moderna said, this is something, and the word Moderna stands for modified RNA. And that's why they named themselves Moderna. And they decided that they can make a lot of things, and one of them was vaccines. So the milestones here, a quick look at a timeline. This is a little bit a busy slide, but I think you need to understand a lot of research before we got to where we are. And again, a reason why you should understand why this vaccine is a miracle. So in 1961 was the first time anyone talked about messenger RNA. That's when we discovered that this RNA carries a message about a code for building a protein. That's how all the proteins in plants and animals are made, through a messenger RNA. So this is one. So I'm going to just point out three important landmarks here. They're numbered for you on the slide. Number one is the very first time in 1990, Wolf, the leading researcher there of that paper, published how you can do in vivo, in other words, in a live animal model, in this case rats, you can use RNA to make a specific protein, whatever it be. So if you're missing a protein, you can send this RNA into the rat and make it happen. So when this was published, 1990, that's what got Katalin Karikó intrigued. And she said, we can make this in humans. And she was not the only one. Lots of scientists decided to jump in. But from 1990 to 1995, all the scientists were thwarted repeatedly. Every time they tried to do it in humans, they failed. And it took another 10 years before, in 2005, as you can see here in number 2, that is numbered there, Katalin Karikó published the paper that broke through everything. In 2007, her publication was accepted. To be able to do messenger RNA in human beings, live human beings. So this was using modified nucleotides. And then finally, the other breakthrough was the medium in which this vaccine can be delivered, because you cannot deliver this, a very fragile messenger RNA, without a lipid nanoparticle, or what we call a fat droplet. So inside a fat droplet, you put this RNA, and that's how the vaccine is made. And this is, again, a breakthrough technology, because without this delivery mechanism, you couldn't make this vaccine. So imagine all of this was ready in 2019, and folks who were ready didn't know it until the vaccine was needed. They were ready. Quick look at vaccine innovations. And if you look at the very bottom is COVID-19, that's SARS-CoV-2. And you can see there, they published on January 10th, the Chinese scientist Xi Zhengli's lab, the Wuhan Virology Institute, published the genome in GenBank. Exactly a week later, both Moderna and BioNTech already decided that they would isolate the spike part of the RNA and make the messenger RNA. 6 months later, they were in the very first trials, and rest is history. By December, both vaccine makers were authorized by FDA after looking at how safe this vaccine was and how effective the vaccine was. Just to give you a comparison, that's a very short timeline. There are other vaccines there, and you can see there, whooping cough. It took a lot of years to get. The green is where the vaccine was made. This first line is where the disease was discovered. So the only closer one is measles, that in 1953, it took them 10 years, 1963 to make it. But this is a miracle to make it in that short a time frame. All right, let's look quickly at vaccine development. And this picture here you see is a spike protein as seen in an electron microscope. And these are different types of vaccines. The ones we'll talk about mainly are the RNA vaccines. This is just illustrative only. And what's important to note here is, here's a picture on the left-hand side. This is the spike protein. This is also the same spike protein. These are electron micrographs. This configuration, what they call a conformation, that's the word they use, scientific term, it is open. In other words, this is before it fuses. It's called pre-fusion conformation. And this is very important because without this understanding, this vaccine wouldn't work. Again, there's a story behind this. 10 years it took for vaccine makers to understand that just using any protein that you as a target for a vaccine won't work. You need to also decide what conformation of the protein. And this is a tried and failed attempt at making a vaccine for RSV. RSV, as you know, respiratory syncytial virus, affects children, causes a lot of death in older folks. Actually, it causes a lot of death in older folks. So RSV vaccine was being developed, and what they discovered there in over 10 years is confirmation is important. And thankfully, because of that, again, another reason that science has been developing, they were able to make sure that you get the right confirmation, what's called a prefusion, just before it fuses with the human cell. That's the vaccine target. That's the shape you want. You don't want this one. This is post-fusion. After it attaches to the cell, it becomes this long harpoon-like, and that's how it enters the cell. But you want it like this open configuration. And this gentleman here, Jason McClellan, is currently Associate Professor of Molecular Biosciences at University of Texas, Austin, was the reason he was able to keep it in an open shape by changing what's called a 2P mutation. He created 2 proline molecules to keep it open. And without this effort, this vaccine wouldn't have succeeded either. So the other folks that really need mention is Dr. Agur Sahin and Dr. Özlem Tureki. These are folks, both doctors, both also researchers at BioNTech in Germany, who immediately seized upon it and made it possible. This January they started. So a quick idea of timeline. You can see January 13th, the sequence was immediately taken up by both Moderna and Pfizer-BioNTech, but we'll talk about Moderna since they released their timeline here. 63 days later, they had first phase 1 trials. And then you can see by July, they had been into phase 3. And by December, they were approved for emergency use by the FDA. And the other vaccines currently approved, not in the United States, but in the United Kingdom, Oxford University vaccine, what they use, this is called a chimpanzee adenovirus, ChAdOx1. So what they use is actually a virus. Both of the vaccines currently in the United States don't have any virus, no virus particles, no virus, nothing. So they're very unique in that. The RNA technology makes it possible, so you cannot get any disease from any virus because there is no virus. But this one has a virus. It's not the COVID virus. It's the chimpanzee adenovirus. Now, adenoviruses cause common cold. This is when a chimpanzee gets a cold. They took that adenovirus and used it as a vehicle. That's why it's called a vector vaccine. A vector is a vehicle to carry the RNA to inform us how to make the protein. And the Russians did a slightly different approach. They also went with the adenovirus, but they used 2 different adenoviruses, Ad26 and Ad5. These are human adenoviruses, not chimpanzee. Okay, so quick comparison. The Moderna vaccine requires 2 doses, so does the Pfizer-BioNTech. Both are RNA vaccines. These are the ones in the United States. And the difference is the Moderna requires a minus 20 degrees Celsius storage requirement. So that's freezer temperatures. But the Pfizer requires Arctic temperatures, so minus 70 degrees Celsius. So you need a very ultra cold storage requirements. Monument Health has that. Only large health systems have that. Now, the Oxford University vaccine and the Russian ones require just fridge temperatures. But you can see clearly these 2 RNA vaccines, even though they require very difficult storage requirements, they're very effective and very safe. All right, let's look at how this works. So there's the coronavirus I've explained to you. It's got those spikes and it attaches to our cells, causes disease. And so what they've done is taken the small messenger RNA that carries the code for a specific protein, the spike protein, put it inside a fat droplet. They call it lipid nanoparticle. These are really tiny. If you wanted to see one of these nanoparticles or lipid drops or fat drops, you need an electron microscope. So these are tiny. You cannot see them. That's how small, and that's all there is in this vaccine. There are no preservatives, there's no mercury, there's no thimerosal, there's no latex, there's no eggs. This is a very simple vaccine in a manner of speaking. It doesn't have anything more than a fat droplet and the RNA in it. So this is how it works. You have the spiral here on the left-hand side of the image. That's the RNA. This is the genetic makeup, but it's not the entire RNA. It's just a very small, tiny portion of the viral RNA, but this is made in the lab. This is not made from a virus. This is synthetic messenger RNA, so there's no virus involved. So it carries the code. to make a specific protein called the spike protein. So here comes the vaccine. You inject it into the shoulder of the arm, muscle of the shoulder of the arm. And like I said, just a fat droplet, nothing else. Once it enters the cell recognizes the messenger RNA. That's how all of our cells make proteins. They need a messenger RNA. So this synthetic messenger RNA carries the code. The cell makes this golden spike protein. Once that's made, the human body recognizes that as not human and makes antibodies, red antibodies, Y-shaped, that immediately recognize and neutralize the spike. So this person here is immunized. When they encounter the virus is unable to latch onto the cells because these antibodies immediately glom on to the spikes, prevent the virus from entering cells. Additionally, this vaccine also generates what are called cellular immune response, cellular immunity. So it creates T cells, killer T cells that will, in case the virus escapes the antibodies, these killer T cells are there to destroy the virus. So it's no wonder it's so effective, 95% effective. And like I said, there are very few components. That's what makes us very safe. And these are all the components of the vaccine. It's very simple. There's the mRNA. Each one is prototypical for each company. Then there are fats, salts, sugars, buffers. That's it. And these are nothing more than very tiny amounts. When they say you can only see in an electron microscope, we're talking about microscopic amounts. And that's all it is in this vaccine. And then the other question they always asked is, did we shortchange the process of trials? Did we cut this short? No, the answer is not at all. So starting on the left-hand side, preclinical research is when you establish what type of vaccine you make. Luckily for us, we had 10 years of prototyping this RNA vaccine. They were ready. They identified the spike protein RNA and made it. Went into animal trials, made sure it's safe in animals. That's the first step, because now you're ready into human trials. So phase 1, 2, and 3 are human trials. Start with about 100 volunteers, look at safety. That was successful. Move on to the phase 2, 100 plus volunteers, make sure the dosage is right, and then efficiency. And then finally, phase 3, the most important part of all trials. So they had about 44,000 participants in the Pfizer-BioNTech trials, and about 30,000 in the Moderna trials, and about 74,000 human participants later. They concluded not only is it extremely safe, probably the most safe pharmaceutical agents ever created, they were also most effective in stopping the disease. So to summarize, 95% for the Pfizer-BioNTech vaccine, very effective even in the greater than 55-year-old population. Same with the Moderna vaccine, 94.5% effective, and very effective in the 65 and older at 100% effective. And then DART, the DART stands for Developmental and Reproductive Toxicity Trials. So these are only done in animals for ethical reasons. These are to test to see if these vaccines are safe in pregnancy and at childbirth, and does it affect the fetus or the embryo or even the child. The good news is both vaccine makers did these trials on animal models, rats, and no effect on female reproduction, no effect on female fertility, no effect on development of the fetus or the embryo, and after birth, no effect on the infant either. So this is why, once again, the safety of these trials are astonishing. And what's good is after these DART trials, usually that's when the scientists feel it ethically okay to actually then look at trials on pregnant women. Just to give you an idea how much these vaccines have been approved by independent review boards, not just in the United States, in Canada, and all these other countries. These are world-leading experts in vaccinology, immunology, infectious disease, epidemiology. And they look at these from a variety of perspectives before saying it's okay to give it to the general population. So you can see most of North America is covered between Canada, US, and Mexico, large countries like Chile, Argentina, Ecuador, all 27 nations of the EU, including the United Kingdom, Switzerland, most of the countries in Middle East, Malaysia and Singapore in the Far East, Australia and New Zealand, all of them approved the Pfizer-BioNTech vaccine. And same here, story for Moderna. You can see a large number of countries approving it. The Oxford vaccine also, you can see large countries like India, Brazil, and you can see in Morocco and Great Britain. And then the Russian, you can see again all of Russia, some countries in Africa, and then also in South America. So let's move to some questions that are frequently asked. I think this is the part I would like to spend most of the time. So a question commonly asked is, if I've had the infection, is it okay for me to get this vaccine? Absolutely yes. Several reasons why. Number one, it is unknown what your immune response was. So what we do understand about this disease is if you were exposed to a lower viral dose when you were exposed, your response may not be as robust. And if you were exposed to a large dose, maybe. And then in between, there's a whole spectrum. So because we have no idea how your immune mechanism responded and what your immune status is, the correct answer is to get it. And it does not in any way interfere with you, even if you got the infection recently. So as long as you finish your 14 days of quarantine, go get the vaccine and it will protect you. The second reason is variants. So the vaccines are really designed well to provoke a good immune response. Even if the variants are slightly less responsive, you get enough titers of the antibody, you will protect yourself. And finally, the last reason is reinfection. If you don't get this vaccine, you're at high risk for reinfection. And then if you're getting any vaccine like a flu or a shingles or any other vaccine, please wait 2 weeks. And if you receive plasma or monoclonal antibodies, please wait 90 days before you get this vaccine. And no need for testing. Testing does not help to decide if you need to get it. The answer is always get the vaccine. And we want at least 80% of the community to be vaccinated. And then question about fetal cells. No cells were used in the manufacture, production, or at any time. And this is a sensitive topic because rightfully so, people are concerned about ethical nature of vaccines. I can reassure you that this was done in a very ethical manner. No fetal cells were used, no aborted fetal cells were used, no human cells were used. These were all synthetic messenger RNA. And then these vaccines do not contain any preservatives. They do not cause Bell's palsy. I'll talk about that a little later. And then transmission. Question commonly asked, if I get the vaccine, I know I will be protected against the disease. Will I also be unable to transmit? The answer mostly is yes. I'll kind of explain that in a minute, but a recent paper published last week from the University of Cambridge, United Kingdom, on the AstraZeneca vaccine, which is a viral vector vaccine, showed that it is 66% reduction in transmission for those who receive one dose of the vaccine. And that's not an RNA vaccine. So we know the RNA vaccine produces a much more robust immune response. So here's a picture here. So this is for all respiratory viruses, and COVID-19 is caused by a respiratory virus called SARS-CoV-2. And once it infects, it usually infects these passages. So nasal passage, the oral passage, the pharynx, the bronchus, the lungs. So these are the infected passages. So what this infection produces is an immune response. So we, the humans, our immune response creates two types of antibodies. The ones in the lungs, they're called IgG, immunoglobulin G or antibody G. This immunoglobulin A or antibody A is only present in the nasal passages. So when vaccines are given, they're not given through the nose, they're given through the muscle here. And so it only generates a systemic antibody like a G, which is very effective in preventing disease. But you could, theoretically, less than 10% or 5% of folks who got the vaccine could carry the virus in their nostrum, which is why we say until we get to 80%, even if you got the vaccine, please wear a mask, please wash your hands. You could be inadvertently passing on this virus. Pregnancy, we talked about that, very safe. The CDC, the American College of Obstetrics and Gynecology, and the Society for Maternal Fetal Medicine, all three uniquely agree on this, that it should be offered to pregnant women because the risks are huge. The risks are, if you're pregnant and you get this disease, COVID-19, you will get respiratory complications at a higher rate than those that didn't, and you might end up in the ICU and require mechanical ventilation. The other risk is you will get a higher risk of premature birth. So your child will be born too prematurely, and that is a high risk. And so these two risks are existent and real. And these are based on statistical findings of COVID-19 disease, which is why, even though there are no human trials yet saying it's safe, we know animal trials that these vaccines are safe. These three organizations, CDC represents public health, American College of Obstetrics represents women's health, and then Society for Maternal Fetal Medicine looks at both fetus and maternal well-being. So all three conclude together that it's definitely worth. And you can also see 227 pregnancies enrolled as of January 22nd in VSafe. In other words, these folks have received the vaccine and they have decided to actively inform the CDC if they're getting any adverse events. So far, none. And then you can also see here, total of 15,000 pregnant women have received vaccines combined, 6,500 Moderna, 8,600 from Pfizer-BioNTech. So before I move on there, I saw a question asked, people asking how many abortions have occurred after someone received the vaccine. The answer is none related, zero related to the vaccine itself. And I'll explain that in a minute. There's a background rate of occurrence of abortions based on underlying conditions. So there are high-risk pregnancies that are caused by several factors. Those high-risk pregnancies that are high risk of abortions. As far as normal pregnancies, there are none that had deaths, and those that did have are always investigated by CDC, including autopsies of the fetus, and all have been concluded to have no relationship to the vaccine, and they all actually had underlying high-risk conditions that led to that. So the answer is zero abortions have occurred that were related to both vaccines. And then pediatric trials are underway currently. Pfizer-BioNTech, Moderna, Janssen, which is part of Johnson & Johnson's pharmaceutical company, and then AstraZeneca, Oxford University. They're all undergoing pediatric trials, and these should be, the early results should be September, and we need our pediatric age to be vaccinated as well. I will say one other thing. Usually, if they're safe in adults in the phase 3 trials, they usually, all of the vaccines thus far we have ever made are usually safe in pediatrics as well, but we'll have to wait for these results. Immunocompromised, if you're immunocompromised, you have cancer, you have transplant patient, or you've had rheumatoid arthritis, lupus, you're on immunosuppressant medications, absolutely you should get this vaccine, but you should always have a shared decision-making conversation with your doctor to make sure you assess the risks and benefits. Same as if you are pregnant, you would be having that conversation with your doctor. Together, make a shared decision if it is worth it to you to avoid the risk of getting COVID-19. Because the reality is those immunocompromised folks, if they get this disease, they don't do well. Incidental illnesses. On an average day in the United States, there are 328 million people that make up this country. 110 people develop Bell's palsy, 274 develop Guillain-Barré syndrome, none of which are related to anything. In fact, the triggers for this are unknown. The research is still outstanding. But the reality is, anytime you hear an association between this, it is not a true association. It's not a true causation. It's just an association. Folks get really concerned when sudden death occurs. That occurs every day. When seizures, heart attacks, strokes. Remember that there are underlying conditions that cause these. As long as these are not occurring at a higher than background rate, and that has not been the case in the trials involving 74,000 volunteers, and not after 28 million doses have been administered in the United States as we stand today. Allergies, the only allergic reaction that you should be concerned is the first dose. If you get an immediate severe anaphylactic reaction, then you should not get your second dose. For all other allergies to food, to pets, to latex, to other medications, you're okay to get this vaccine. Anaphylaxis rates, this is important. So far, as we have given away 28 million doses of both vaccines, the rate is 2.8 per million doses for Moderna, 5 per million doses for Pfizer-BioNTech. To put it in context, penicillin, 1 in 5,000 folks undergo a severe adverse event. So compared to that kind of numbers, these are extremely safe agents. And the reality is these numbers will keep going down because when we finish about 200 million vaccinations, what we've noticed is it's always less than 1 per million that you get what is a truly anaphylactic reaction. The other important thing to take away is all of these reactions, totally 71 cases in the United States, they all recovered. There were no deaths related to anaphylaxis and no deaths directly related to the vaccine itself. And then I will quickly move on to one quick look at these adverse events. These were reported to the CDC. What you'll commonly encounter is pain, fatigue, headache, muscle aches, chills, fever. It feels like you've got a little like flu-like symptoms, but these should resolve. They always resolve. People undergoing this feel really miserable. They take a day off from work, but you have to weigh that against the risk of getting COVID-19, which is really dangerous. It affects your brain, the heart, the liver, the lung, and causes blood clots in your blood vessels. And most recent research shows that folks who even got COVID-19 and did not know it, had no symptoms, when they look at their chest x-ray a month out, it looks really bad as if someone had smoked for 10 years. So there's some subtle effects that we're only beginning to realize. Not everyone gets it, but those that do, it's not a good outcome. So it's important to get the vaccine. Remember, these are reactogenogenic. These are not real these are just effects of the vaccine. They are not bad, and they'll go away without medical intervention. More importantly, now you're protected against this disease. So I'm going to rush through some of these. Make sure you get your second dose. Do not skip the second dose because you didn't feel good for the first one. I hear a lot of that. The important reason is if you don't, you're susceptible to reinfection, to variants. And then herd immunity threshold, we need to get to 80%. Just to give you an idea, for SARS, because it's airborne droplets, 2 to 5, a reproduction number, you need 80%. For measles, it was 95%. You need to get to 95% vaccination of community. But good news here, we can get to 80%, will be good. 80 is what we want to shoot for. All right, just these are all vaccine preventable diseases. Remember, vaccines prevent deaths. Vaccine prevent diseases. What you want to do is prevent. Prevention is better than cure. You do not want to suffer the disease and its consequences. All right, quick look at variants. This is important. So remember the bead analogy I gave you? So a string of beads here. So you can see here the spike protein is coded for this small portion of these beads. And this is where the concern arises. When the virus changes these arrangement of these beads, you have a change in this arrangement of the spike. And that's what folks are calling variants of concern. And we'll look at that. But these are less than 10 out of 30,000. These numbers, I'll talk to you in a minute. This is the genomic diversity. All of these, starting from Wuhan, China, the colors most common you see is this range of colors, this beautiful blue to purple range. And they all account for what is called B1 lineage. The B1 lineage is the predominant one. The sequence 0, that is the Wuhan ancestral strain, is very similar. The only difference is there are some lineages out of it. And here's what I'll talk about. We'll skip this. Mutation rate is very low for this virus. This is the spike protein, and I will show you. And this is spike protein. It's attaching to a receptor on the human cell. And these are the changes we're concerned about. Here, right here, N501Y. Here's a deletion here, and there's another spot here. And this variant of concern that began in the United Kingdom is called 2020 December, the first variant. And you can see how far it's spread. It's these darker shaded countries are where it's mostly, like in the UK and even in the United States. And if you look at all the variants we're concerned about, the United Kingdom has 8 changes in the spike. South African has 10 changes. Brazil has 12. California has 5 changes. Remember these numbers, they're only less than anywhere from 5 to 12 out of 30,000 beads. So these are minuscule changes. The virus still behaves the same way. The only way you can protect against this virus is washing your hands, wearing a mask, avoiding crowds, and getting the vaccine when you get that chance. So please register, and I'll show you how soon. And this is the variants by type in the United States. The UK and the Brazilian variants only have seen in the Minnesota, but the rest of the states, the green color states, are where the UK variant has first made an appearance. The fact that you don't see anything here is not real. In all honesty, we already have these variants in our midst, and I'll explain in a minute why. The South African variant is only first emerged in South Carolina so far. So if you look at the emerging variants in the United States, this map is from CDC. You can see the largest numbers are reported in California, Florida, New York, and there's reason why. Look at sequences submitted. These are genetic sequences submitted. South Dakota does not submit much more than 6 or less than 70, and the biggest, largest submissions are from these states, and which is why you're seeing that. But the reality is, just because we didn't submit doesn't mean that we don't have the variants. We have submitted very few. All honesty, right here in this state, there are already 15. I'd be surprised if we don't have 15 here in South Dakota already. So if you just look at the ranking, we are 43rd among countries that sequence well for these viruses. Australia and New Zealand lead, and Britain is up there too. They submitted a large number, 7% of theirs. We do 0.3%. Australia and New Zealand closer to 50 and 60%. So what are we doing differently? We're doing a lot differently. Starting this year, we have these 4 agencies just going all out to increase our surveillance, increase our percentage of sampling. All right, vaccine distribution. You can see the percentage of population that received first dose. The leader is Alaska, 13.4%. A great story here. You know what they're calling this project? The Alaskans call it Project Togo, and I'll explain in a minute why that's very cool. But they're doing a great job. South Dakota is doing a decent job, 8.9%. The State Department of Health has done a great job in getting vaccines out to Monument Health. And if you look at the population that has completed 2 doses, we are very good, 3.6. Alaska is leading again at 4%. And then if we are going at the current pace, we should get to half of the population in the United States vaccinated by July and 90% by November. So by fall, September, this country, if we go at the current pace we're going, we'll be in good shape because that's where we want to get to, somewhere about 70 to 90%. All right, I will skip this slide and want to focus on this one quick. So those of you who are 80 and older and 75 and older, you're getting your vaccines right now. We hope to get most people 65 and older by completed by, like March, end of March. And then April and May onwards, we can see most of the population getting vaccinated as well. And so if you will remember one slide, please remember this one, vaccine register. .monument.health is where you want to go to register, or just go to our website and you can know how to, there are links, quick links to get you there. Please register so we can plan better. If you can't access an internet line, just call this phone line 755-1350 and we will get you registered. And I want to end with this picture of Togo. So Togo is a sled dog, Alaskan sled dog. And there's a Disney movie if you want to see it, but movies aside, this is a true story. So in 1925, the town of Nome, Alaska, was facing an epidemic threat that could ravage the entire Seward Peninsula. All those folks there. It was diphtheria. The only way they could save these poor children and folks dying, because what diphtheria does is it creates this large swelling in the back of your throat, and then you die by choking because you asphyxiate to death. So the only way you could save these folks was to get that antivenom, the serum, diphtheria serum. So there's a famous serum run that ran from Anchorage, from Fairbanks to Nome. And the only way they could get there was a blizzard going on, and the only way they could get there those days, 1925, was through sleds. And there were several dogs that led this. There were 20 mushers and about 150 dogs. But this dog stands out. Togo ran 500 miles in the blizzard and was the reason why the large shipment got to Nome in time to stop this epidemic and rescue these folks. And to this day, this is why the state of Alaska called their project Project Togo. So Togo is to be a remarkable story. So having said that, I'm open to questions, happy to take some.
Dr. Kurra, that sounds like that could be a great turtle soup program when we start getting everybody together. We could do Togo.
Yes.
So thank you for the awesome presentation tonight. We're blessed in our area here, folks. I was talking about Dr. Kurra at a group, and someone there said he is our area's Dr. Fauci, and I shared that with him tonight. And I really do think you've been a tireless communicator. I've got some questions here. You did such a great job. You wiped some of them out, but I'm going to kind of reorganize a little bit of them too. But one good question that I think to kind of start the Q&A with is that what was your reference point for some of your data and details? I saw on a couple of the slides there might have been a reference to CDC, but could you talk to it a little bit greater detail there, Dr. Kurra? And I know we'll make this content available too, but that question came up.
Excellent question. So I'll start, as far as the technology is concerned, that is entirely from journals, virology journals, Cell, Nature, These are usually not the journals you'll hear about, because you'll hear the Lancet or the New England Journal of Medicine or those kind of journals. Those are different. These are more niche journals where you're talking about researchers in vaccinology, immunology, and that's where all of my RNA material, the material that I researched. But as far as all the other graphs and data, everything links back to CDC, pretty much 100% to Johns Hopkins and CDC. And they're just, the way I curate and make sure that this is, validated is if I borrow that graph or a slide from that, or for my slides, I make sure that it is referencing back the data. And it says in the article, each of those, it is CDC data or Johns Hopkins data. So this is very carefully curated information that is based on solid evidence.
Thank you, Dr. Kurra. I'm going to kind of change this question just a little bit because I think you were very compelling throughout the presentation, but I want to pay respect to the questions of people still perhaps wanting to be cautious and maybe wait for more data or details. But I'm going to kind of twist the question up a little bit because, can you compare the success rate of some of these vaccines to maybe some of the prior efforts? And maybe that will give people a better context, right? Because it is an incredibly quick turnaround. It's a huge story in itself, but I think you understand people being a little careful.
Absolutely. Great question. I think this is the one question in everyone's mind. And Troy, you'll be surprised to hear it's everyone, not just lay folks, even people in the medical field, doctors. We always question these, and we are concerned when we recommend it to our patients or to ourselves. I've had both doses. But I will say this about the safety and efficacy. The vaccine that is as effective as this one is measles. It is one of the most incredible vaccines ever made, 98% effective. Of course, smallpox is another one, polio is another one, but that level of 90+% efficacy and effectiveness is very rare in a vaccine. And what I would like to impress upon is the reason this vaccine is so safe, and it's kind of hard to understand because when we use the word RNA and folks ask, is my DNA affected? Well, the DNA is our genetic material. It's inside the nucleus of the cell, protected from the RNA. So when this RNA enters the cell, it is not able to enter the nucleus. And what messenger RNAs are universal. These things are found in plants and animals, and that's the only way life makes proteins. Any cell, living cell, makes protein using messenger RNA. And what the body does is it translates the messenger RNA. Once it finishes translation, the natural process is to degrade that messenger RNA. It has finished its purpose. And that's what happens with these vaccines as well. Within a short period of 2 days, this vaccine is gone. And it's already, like I said, trace amounts. We're talking microscopic, electron microscopic level amounts. And these basic genetic material, once the RNA is translated, it is destroyed. And that's just the way the cell behaves. And what I want to impress is it is a natural thing that a cell is doing. So we have come to the level of engineering this to use nature's own way. It's not in a strange way. And we haven't directly introduced messenger RNA. We haven't used a virus to carry it like previously doing, and some vaccines are still doing that. So in that sense, that safety is there. I know when you use RNA and DNA, people are rightfully concerned, but the reality is the trials are great, and they've really shown that, number one. Number two, right now, as we speak, we are collecting information. The CDC is through VAERS, which is the Vaccine Adverse Event Reporting System, and VSafe, which is a more active way of monitoring this. Folks download this app onto their smartphones and then report to the CDC. Every one of those events are followed up and researched and looked at by independent analysts, experts in this field. They look at autopsies, they look at all the evidence there is and make sure, because this will go on. Both these trials, Moderna and Pfizer, are still in trials. They have not concluded that their trials will go on for 2 full years. The FDA gave this approval based on 2 months of data. And the reason they picked 2 months is because that's about the time any vaccine made has been shown to give us information about safety and effectiveness.
That's it's just exciting information about these messenger RNAs. I mean, that itself is a whole nother opportunity for us. So you did a great job on talking about the timelines and the percentages of the community. I had a question. It was a 2-part question. Is once someone has gotten both of their vaccines, what's some guidelines for maintaining the social distancing? And then it's related to how do you know where is the community's immunization level, so that you can understand, is it safe now to remove the safety mask or should I stay with it? But kind of really just trying to figure out what are the boundaries at.
Good question. The simple answer would be we have to get to 80% community-wide immunization adoption. So maybe fall, just to give you a timeline, we'll probably get there late fall. But I also want to say, great question. One of the things I want to say is make sure you get both doses, because the first dose confers some level of immunity and you might be okay. But here's the risk, and this is very important. If you don't get the second dose, what the virus does is it's like it now has selection bias. It can mutate, if you will, or develop mechanisms, because you're still going to be exposed to some level. But after the second dose, the level of the antibodies are so high, the virus can't then figure out a way. Otherwise, after one, the partial immunity, if you want to call it that, creates a fertile ground for this virus to develop new ways to change and then be more dangerous. So this is very important to complete the series, primary and secondary series.
Don't give it a chance.
Yes,
right?
Exactly.
Wipe it out.
Yes.
All right. I got people chatting saying, no worries. We're going to get 2. So
thank you.
In regards to the variants that we were talking about, I had a question come up. Since it would appear that there's a low mutation rate that's occurring right now, do you think that there'll be any need for reoccurring COVID vaccines, or do you think that we may, kind of like how we're doing influenza shots?
Right.
What's your thoughts on that, Matt?
Yeah. So if you look at the best research out there, this is a question that is hard to answer. It could be annual. It'll depend on how endemic this virus gets. So it's simply explained, influenza comes back every season. It goes down, fades away, comes back. That's called endemic. In other words, it's always in the background, even in the summer. But it's just not in large numbers, so you don't see it. And then every winter it rises again. And there's reasons behind that. But that's what we say. If coronavirus SARS-CoV-2 becomes endemic, then you'll need something like that. And that will be decided by how quickly we lose immunity. And we won't know that until at least, next year.
Okay. All right. So that's like still more to come, right?
Still more to come. Yes.
So under that category, Dr. Kurra, I mean, we've got a couple vaccines that are out, and you talked about some of the vaccines that are in other areas of the world, but what's forthcoming here in the United States? Do you see something else coming soon too to kind of aid in everything that's happening?
Yeah, it's exciting. Great question, Troy. So Johnson & Johnson, its pharmaceutical branch, Janssen, is very close to applying for emergency use authorization to the FDA. Their timeline this month, and then they're very confident they can get millions of vaccines out by April. So that's one. The other one is the AstraZeneca Oxford University vaccine. They're going to apply for emergency use authorization as well. So we'll see how that goes. And then Novavax is the other one that's completing its phase 3 trials. So we could be looking at additionally 3 other vaccines probably into summer. And that might really speed up things. That would be great if that happens.
Yeah, that was going to be my follow-up question, which was, well, will that change your projections on?
Yes. Yes.
That would be wonderful, wouldn't it?
Absolutely.
Instead of 70% by September.
Yes. Yeah. So this projection is based on numbers from the VAERS CDC reporting. So at the current rate, we're going at roughly 1.3 million doses are being given every single day in the United States. And if we keep at 1 million even daily, and like the new president said, 100 days, we'll get there. Well, that's the rate we are assuming in that graph. But that could change quickly. If you get even one vaccine, even if you get Johnson & Johnson in the game.
Hey, why not? Let's just go faster on everything. We created
Right.
the vaccines quicker than ever before, and they're effective, and why not go a little quicker, right?
Right.
I'm all for it.
Yes.
So Dr. Kurra, I had a comment that came up based probably on the, I know it was based on the mutations and that question there, but there's other diseases that have gone away, like SARS and things of that nature. Why might not COVID-19 or variants just disappear?
Yeah, I think that's an excellent question. So this is very clear now after a year of COVID-19. So the reason SARS went away, it started in 2002. By 2003, September, it was gone. And the real reason it's gone, and this is called extinction of a certain virus, is because it was carefully controlled. And the reasons are many, obviously, because it doesn't spread one as fast. And it requires a little more, the spreading requires a little more than just brief contact. So that's one. MERS, the other coronavirus that's now endemic in the Middle East, from camels to humans, it's still endemic, it's still there, but it is not widespread. It's not pandemic. The difference for influenza and this SARS version 2, COVID-2, is they have the ability to rapidly spread. The only way we could have possibly ended it early is if we went into severe lockdowns like China did. And that is difficult to do. You can see the economic toll. It's a global world anymore. We need to look at the world, not just the United States anymore. And the same applies to vaccination. So short answer is, right now with SARS-CoV-2 so widely spread, it's more likely that it will become endemic. The only other chance is if we all get vaccinated. And here's the trouble, Troy. There are a lot of countries in the continent of Africa. And there are countries in Asia, including India and China, that is difficult to get these vaccines to everyone. And if you remember the journey with polio, we were able to eliminate it everywhere except a couple of countries in the world, in the high hills of Pakistan, where we cannot get the vaccine. And the same applies to smallpox. The only reason we could get rid of it is we were able to get it everywhere. So the world needs to pay attention and make sure these countries that are not wealthy get the vaccine as well.
Excellent point. Excellent. As a Rotarian and fighting polio, that's what this is all about, right? Is get those vaccines to everybody. Yeah. Dr. Kurra, again, it was towards the end there, but we got to register to get into the queue to get the vaccine, right? So we want to encourage everyone, even if you're a young guy like me, to go get registered.
Absolutely.
And so again, why don't you give everybody the where to go on the website, just so that.
Thank you. So this helps everyone. It helps you because then we will call you back. And I promise this is what we've been doing once you register, when your time is up to get it. So vaccineregister.monument.health, or just go to our website and you can find the link. If you can't, the other thing you want to do is call our triage line, 755-1350, and we will put you in the line, call you when it's time, and it really immensely helps us do the logistics. So then we can arrange things. What we're going to do is give most of these vaccines starting February 8th at the mall, Rushmore Mall, and the Herberger space. But we'll also have multiple satellite locations in all the smaller towns. So don't worry. If you register, it'll ask you if you're in Custer or Lead or Deadwood or Sturgis or Spearfish, anywhere, Philip, Martin, you can get it there because we will reach out and make sure everyone. Our mission, Troy correctly pointed out, is make a difference every day. And we want to make a difference to the communities of the Hills and West River. So we are here for you and help us to help you.
Dr. Kurra, that's a great way to finish it. And as I mentioned at the start, Monument is serving over 20 communities. And obviously this is the way to do it. Go get registered. They'll get you pulled in. And it's really exciting to hear that you're opening up places like out at the Rushmore Mall and other spaces to be able to speed these vaccines into our communities, because the key is getting everybody immunized. And Dr. Kurra, is there anything else you'd like to say before we wrap up? I think we've covered, you answered a lot of questions, and thank you folks who were sending questions in, and then Dr. Kurra wiped your question out before I could ask it, but he did a great job. But anything you'd like to add, Dr. Kurra, before we sign off tonight?
Yeah, I want to thank everyone for joining me on this. This is very important. If you can share this with others, please do. One other thing, please stay safe. Wear your mask, wash your hands, keep your distance, don't gather in crowds, especially in closed spaces with poor ventilation. Your best chance against this disease is prevention. Please, if you can protect yourself till you get the vaccine, and those of you unfortunate enough to get the disease, please don't stop because of that, because you want to protect yourself. These vaccines are safe, number one, but give you the right amount of protection for any other reinfection or variants. So please get in line, get registered, and stay safe, folks.
Thanks so much, Dr. Kurra. And for all of you who've attended this tonight, we will be editing and repurposing this program and distributing it again at free at no cost to everybody. Our journey discussions are at no cost at all. I mean, when we made the decision to do safe programming here into 2021, not try to bring you folks into our theaters, and we wanted to be safe, we decided to just kind of forego the whole idea of admissions. But I'd like you to know that there's no donation that's too small. You can go to journeymuseum.org and make a donation. We would appreciate that, but we're going to persevere because we believe that we need to serve our community by providing this type of information and education for everybody. Probably it's even more important right now when there's so many fewer options, and we do need to be safe. So on behalf of the Journey Museum and Learning Center, Dr. Kurra, thank you again for joining us from Monument Health. And folks, thank you for joining us for our journey discussion. Stay safe and do share this message as we go forward. So good night.
Thank you all. Good night.